Welcome back to the Win Back Academy podcast, where we bring together voices from across our academy, clinicians, educators, and field experts, to explore how TECAR therapy is being applied in the real world. Not just protocols, but clinical reasoning, cases, and integration into patient care. I'm your host, Ramona von Leyden, PhD, WinBack's Senior Director of U.S. Medical Affairs. On this episode, we're sharing a replay of our May Ask Me Anything conversation on whiplash, cervical syndromes, and multi-modal TECAR application. This discussion features Don DeFabio leading the conversation, joined by our other panelists, Dennis Donovan, Andrew Schwab, Grant Headley, and Laura Ramus, as they explore different clinical approaches to cervical conditions and the integration of TECAR therapy into patient care. Let's get into it.
Good evening, everybody. Welcome to this month's WinBack Academy Ask Me Anything. I'm your host, Dr. Ramona von Leyden, and each month we bring together clinicians and educators from across our academy to discuss real-world application of TECAR therapy in clinical practice. Today's discussion is focused on whiplash, cervical syndromes, and multimodal TECAR application. Tonight, we get the pleasure of Don DeFabio leading the conversation, joined by our other panelists, Dennis Donovan, Grant Headley, and Laura Ramus, as we explore different clinical approaches to cervical conditions, rehab strategies, and integration into patient care. So Don, without further ado, I'll hand it over to you to get us started.
Cool. Thanks, Ramona. It's great to be here tonight. And I want to thank everybody for tuning in. And it's going to be fun. We're going to go over a lot of interesting information and give you some ideas on how we can apply the WinBack TECAR for cervical syndromes. And it should be a lot of fun. Let's just get this up on full screen. There we go. And I want to minimize this. Cool. All right. So thanks for that intro, my dear. I'm a chiropractic doc. I'm board certified in chiropractic orthopedic sports and rehab. So I have different perspectives at different times. So I might put my rehab hat on, my sports hat, or my non-surgical orthopedics hat on at different times to give different perspectives. So we might be jumping around a little bit, but basically we're looking at from the neck up, not from not your head. We're not going to do any supratentorial work today, but basically that thoracic and cervical spine, the cervical thoracic region. I always like to start with some basic relevant anatomy, some guidelines. We have the cervical spine, and of course, we have all of the cervical brachial nerves that come out. You have your occipital nerves that go up into the head, into the face, into the brain stem. Your brain stem comes down into that Atlas C1 area. So it's a junction box of a lot of neurological input, efferent and efferent. But again, all of those brachial nerves go down the arms. Then you have your sympathetic chain ganglia there. They also get impacted. All the thoracic outlet, the neurovascular bundle there can get impacted. So again, there's a lot of things going on neurologically up and through that area. We're not going to go over nerve root tension and compression signs and all of those things, but we do want to remember about that. Obviously, we're going to spend a bunch of time talking about the myofascial component today. And again, just think about that anatomy, because as you think about the anatomy, then you're going to get better outcomes, right? An accurate diagnosis is going to give you better outcomes. So you have to kind of just browse through that anatomy and figure out, is it disc? Is it nerve? Is it muscle? Is it ligament? Is it capsule? Is it referred from somewhere else? What's going on, so that you can get a handle on how to approach it. So we want to think about your superficial global muscles, your traps, the levator scat, even into the shoulders. You got the rhomboid muscles, the shoulder girdle and the thoracic spine. They're going to be players here. We're going to talk about that in a little bit, but then your erectors, the longissimus, the semispinalis, the splenius cervicis, just remember about those guys. And as you go deeper, you're going to get into the intrinsic stabilizers, Posteriorly, your multifidi, your rotatories, right? And again, those erector spinae up in that suboccipital area. The suboccipital area is huge for chronic pain in the cervical spine. Can it be a player in acute pain? It sure can. And for the chiropractic doctors out there, they know about upper cervical specific. I mean, that was back in the day, 100 years ago, one of the premier chiropractic techniques was just working on adjusting, manipulating C1, occiput C2, that area, and let everything else proprioceptively follow in place. So very neurologically dense area. It's one of the three highest, fun fact, your suboccipital area is one of the three highest proprioceptive centers in the body. So now, can we throw out a 25-cent poll question to the panel? Anybody know the two highest other proprioceptive centers in the body besides the suboccipital area? Any takers? Any guesses? SI joint, and then the foot, subtalar joint. Those are the three highest proprioceptive centers in the body. So you want to make sure they're all taken care of. But posteriorly, we want to think of those larger muscles going deeper, going down to the ligaments in the capsules. Anteriorly, you got your deep cervical flexors, right? Everyone thinks right out of the box, cervical syndromes, whiplash, neck pain. Okay, you got to train those deep cervical flexors. Yeah, they're important, but you can't forget the posterior chain as well, right? Going the wrong way. Here we go. So those deep stabilizers posteriorly, we just blasted through them. We don't have to hit all of them by name, but I want you to remember that suboccipital, very, very important. Very important. And those deep intrinsics, the multifidi, the rotatory, as the rotatories, as the splenius, cervicis, and capitis come up. And then anteriorly, longus coli, longus capitis, your scalenes. Again, not only are they part of the myofascial component, where do those nerve roots that come out and come anterior go through? Either go through or wrap around your scalenes. So if your scalenes get injured, if your scalenes get jacked up, it's definitely going to create brachial nerve problems, cervical nerve root problems. And again, anteriorly, we have all those cervical sympathetic ganglia, right? So maybe those Raynaud phenomenon people, maybe those people with some of the whole hand numbness, the whole hand coldness, not just the C5 distribution, not benediction hand, not just the ulnar distribution, but the whole hand, top and bottom. You got to be thinking cervical spine, because that's the only area where the nerves that are going to impact C5, C6, C7, and T1. It's got to be up in the cervicals, okay? And then, we always look for something called doorbell sign, where you palpate those anterior cervical chain along the scalenes. You try to get your fingers really on the transverse anterior aspect of the transverse process and challenge that. And sometimes you find a nodule in there and it, boom, shoots right down the arm. Then you know it's coming from that, again, anterior cervical chain. Is it a scalenus anthicus syndrome? Who knows? That's not the point. The point is be aware of it, check it, and just refresh up on some of that anatomy, because that's what we're going to be dealing with today, right? A little bit about kinematics of the cervical spine, because we want to create motion where motion doesn't exist, and we want to restore motion, whether it's aberrant or not. So just think about the atlas. Remember, 50% of cervical rotation occurs at C1, C2, all right? The rest of it occurs in the lower cervicals, primarily at C4, 5. For the people who are watching, because I know this is a podcast, you can see the vid or the picture here. When you rotate to the right, you can see how the atlas would rotate on the axis, but you also get lateral flexion to the opposite side, to the left. There's a translation and a tilting. So it's not pure rotation. It rotates, tilts, and laterally bends a little bit. So that's what's happening at C1, C2. Palpate that. If you don't know how to palpate that, and you don't know how to feel whether it's rotating properly and you're getting that translation laterally at the same time, you're not going to be able to restore the mechanics up there. By the way, rotation C1, C2, very, very little rotation occurs at the occiput atlas. That's going to be flexion extension. So someone who's got flexion extension issues, okay, maybe it is the occiput on the atlas is where the dysfunction is. Whereas if it's rotation, you got to be thinking C1. The cervical flexion rotation test, right? You put the patient into cervical flexion, they're prone, passively you rotate them in full cervical flexion first, and then add rotation. It should have a minimum of 44 degrees, okay? If not, there's dysfunction up there. And if there's headaches, it's pathognomonic for cervicogenic headaches. But let's look at the lower cervicals. So remember, when you laterally flex to the right, you're going to get left spinous rotation, all right? When you rotate to the right, you're going to get that same translation of lateral shift to the left and contralateral spinous rotation. Now, why am I talking about this is because, well, number one, I'm a chiropractic doctor and I palpate these mechanics. Number two, wind back is such a great way to restore these gently and efficiently, especially after the neck's been traumatized. So you want to know what you're feeling and you want to know what you're looking for in terms of the kinematics of the cervical spine. So a little bit of a brief review on anatomy and kinematics. Let's get down to some clinical stuff. Cervical spine syndromes, they could be traumatic or they could be not traumatic. I woke up like this today, doc. I can't move, right? Or the guy that comes in, I can't turn around and look over my shoulder anymore in the car when I'm driving. Well, it's been slowly building up, but it finally got to the point where they decided to do something about it. But if it is acute, that's going to fall into our whiplash-associated disorders. It could be a motor vehicle type of acceleration, deceleration injury, or it could be they slipped and their head snapped back. Maybe they didn't fall, but their head just snapped, right? Or maybe their dog pulled them while they were walking their dog and it pulled them and their head snapped back, or they turned real quick, so some sort of acute, meaning it's inflamed, meaning it's irritated, meaning it's mad, okay? An acute type of situation. And then we're going to have our subacute patients where, okay, it hurts a little bit. It's getting out of that acute inflammatory phase. And then we're going to talk about the rehabilitative. There, patients feeling pretty good. Hey, I'm feeling pretty good. Can I go back to the gym? Can I do overhead presses now? Can I do upright rows? That's the corrective phase of care. And then lastly, return to play, return to work, getting back to activities of daily living, no matter what it is, whether it's baling hay, whether it's, sitting at a desk all day doing 8-ounce drop sets with coffee and donuts, or is it, going to the high rocks training and competitions, whatever their everyday stuff is. And those are the stages of care we're going to talk about treating today. Okay. Lastly, we're going to hit chronic pain. That's the last thing we're going to hit because that's a different animal. All right. So in general, for our attendees who don't know a lot about TECAR, here's the general stuff. If somebody's in that acute stage, they have an inflammatory situation, we're going to use athermic CET. In other words, personally, I don't want a lot of heat on these people. I'll use the soft setting. CET stands for the capacitive mode. It's going to be more superficial. You can get a lot of heat with that. You can get a lot of analgesia because of it warms it up and makes it feel good. But if it's acute and it's hot, and especially if it is like a motor vehicle accident where I know there's been trauma, I don't know how much the ligaments have been injured, how much the muscles have been injured if I haven't had like an MSK ultrasound. but I can tell by physical exam and radiography that it is a soft tissue injury. I don't want to add a lot of heat to that. So I use something called athermic CET, soft setting. I will use RET though, which is the resistive mode. The resistive mode is going to penetrate deeper. It gets into those tissues that are less water dense. All right. And it's better for the cartilage, the capsules, the deeper tissues. So I want to get those guys some blood. All right. But again, I don't want a lot of heat. Low setting. I'm going to keep it from getting hot. And this is the way I approach it. And again, I'm going to ask the academy how they like to do this, but this is my way of going at it. But then I always stack it with the high tens. And the high tens can really go after people who are really hot, acute pain, or not as painful, but that addresses the nerve component of the pain. In the subacute, I'll still use the CET, but now I'm going to, the capacitive mode, superficial, likes water, likes muscle, right? Now I'm going to let the heat get to 4 or 5 out of 10. I want it to get warm. RET, I'm still keeping it low. High tens, I'm still doing. But here, I may also add the EMS, the muscle stim. Look for those motor points. Maybe start to challenge the muscles a little bit. But again, if they're more sore, if they're more acute, I'm going to stay in the high tens. As they get less acute and they're starting to say, hey, my range of motion's good, I'm feeling pretty good. Yeah, I definitely want to add the muscle stim, the high EMS. The rehabilitative corrective phase of care, still doing that capacitive mode, but now I want it really more because we want remodeling, right? We want remodeling. The RET, now I'm letting it get a little more. Okay, a little warm. So I still do the CET, I still do it the RET, the capacitive and the resistance. I like to stack them both, but the EMS is definitely the way to go. And as we're going to find out, we have to go down into the thoracic spine, all right? And the reason we go into the thoracic spine is because when research has shown dysfunctional thoracic spine is going to put more pressure on the cervical spine. And in fact, for your whiplash associated disorders, they've done studies where they've just treated the thoracic spine with manipulative care, and it's benefited the cervical spine. So you really have to open up the thoracic spine, make sure that there's no dysfunction there. And for our people in the functional movement world, the thoracic spine likes mobility. You got to restore that mobility. And then the return to play, site CET, the capacitive, I'll use dynamic, which is just another setting, a little bit more intense, get a good thermal effect. The resistive, definitely with the EMS, but now I'm adding it with active care. Here's where I add bracelets. Now I like to get my bracelets on. See, Winback's really cool because you can apply the TECAR through your hands with bracelets on. And now I do a lot of my myofascial release there. Again, this is my dynamic. It's not etched in stone. The chronic neck pain people, they need lots of heat. So CET with a lot of thermal, RET, but they're in chronic pain. So now I'm still using the high tens, just a slightly different setting than the acute, because the acute, I don't want that heat. But they also get EMS because we got to strengthen the muscles. So they kind of get it all. We could spend a whole module on chronic pain. I kind of like chronic pain. It's a lot of fun, but very cursory. Dennis, you're like a big guy with all of the intricacies. What do you think? You think this is a good overflow, or how would you address some of these stages? Because I know you're really into using the bracelets and other things.
Yeah, you took the words right out of my mouth, actually. And that's the beauty of WinBack, right? Like I don't need to use it the same way you do, right? So I
Mm,
actually like starting with the bracelets, like for some of my more acute things. And I'll run the
really?
20, yeah, and I'll run the 25 hertz. high tens through my fingers, and at very, very low intensity. So I'm not necessarily changing the parameters you're setting, just my mode of delivery, right? And I find that sometimes, just a little bit, it again depends on how flared up they are, how acute they are, but sometimes like with very, very gentle touch and the current coming through my hands, I really like delivering that. I think there's something nice about the touch of the clinician sometimes for the right patient early on. So I use the bracelets throughout the treatment continuum, but I'll start with them doing acute as well.
That's interesting. Do you still like to keep it athermic
Yeah.
in that acute setting, or do you try to get some heat in there? Because that's controversial. Some people introduce heat pretty early.
Yeah, and it's not to say I haven't, but generally, no, I'm agreeing with you that I run it low, athermically, and I'm doing more just to facilitate like some gentle relaxation of tissue, kind of reduce guarding, maybe a little bit of mobility, all very, very passive, and all very, very gentle, just with the added benefit from a cellular perspective of the energy coming through my hands. I have in the past used the soft CET with someone who was, acute pushing subacute because I wanted them to feel the gentle warmth. I wanted them to feel that superficial analgesia from the soft CET. Definitely not someone I'm seeing like 2 days after the injury. Then I'm still working in low more often than not.
Yeah. Oh, cool, cool. Now, Laura, how about some pro tips? Again, I look at this as kind of an entry level way to apply win back. I mean, you've seen athletes day one and had to get them back to play probably, tomorrow's game, let alone the ones that are more chronic. Are there any pro tips that we could add to this continuum? What do you think?
No, I love the continuum, and I think one of the pieces that you just described is that thermal effect. It when appropriate applied, like I said, not in that acute state. I love to use the athermic, but I also will combine it, as you indicated, with movement, whether that's mobilizations with movement for mobility or stabilization exercises during the actual TECAR application too, because we just know that TECAR is really most effective when we're doing it either with mobility movement exercises as indicated, or if it's a stabilization with an isometric or a concentric or ecocentric exercise. So I would just add that piece.
No, that's good. I know, Grant, you had showed me something, oh gosh, about 6 months ago, where the people were, doing an isometric and then going through a range of motion. And I stacked that in the office and it's been money. So I like that concept. So cervical acceleration, decelerate injuries, whiplash, automobile accident, couple of fun facts. 43% of chronic neck pain is related to a motor vehicle crash. That's from Croft. Croft also documented a car rolling at 5 to 7 miles per hour into another car, 5 to 7 miles an hour. The passenger, a real person sitting in the front seat, not a crash dummy, will get up to 4 Gs of force on their neck. That's how much of an issue this is. And proper headrest restraint geometry can prevent that. So if you are seeing motor vehicle related injuries, your headrest restraint is really important. Go out, look at the car, look at the patient in the car. If their headrest is not 2 inches above the top of their head and 1 inch behind, that's not good headrest restraint geometry. Because the first thing that happens when you get hit from behind is you get thrown. That's why your headrest has to be 2 inches above the top of your head. So, fun fact. Um, Acute, we talked about it. This is kind of what it looks like. The main goal is to reduce, again, Dennis, I'm not using the bracelets, but my hands are on the patient. So, we'll have to just a little bit differently. But I love adding motion. I love adding motion because the one thing you don't want to do is let it scar down. Because once it scars down, you're done. Okay. He wasn't super hot, so I had the high tens at 5, and the RET about 30%. All right. So that's what we were doing. But our goal is to prevent that secondary zone of injury. So that's kind of what it looks like. The subacute. So watch watch the patient if you can. If not, we'll tell you what happens. All of a sudden, whoop, he jumped. So what do you think happened? Hey, Grant, did you see that guy jump on that when I did that? Is he there? Did anybody see it jump in the academy?
Yeah,
The
yes, I
patient jump?
did.
What do you
Absolutely.
think happened?
To hit a motor point.
Or what
Screw
else?
it.
I run into it pretty frequently, those little hairs on the nape of the neck.
Oh, you
If
got
there's
okay.
not
So,
enough lotion there, I
yep,
find they can be a little hot.
gotcha.
Okay.
Okay. And the
It
other
just,
thing
it
that we
just,
can do with that too, Don, is we've talked about this before too, is if you even have more of that hair, just wet it down even before you put the lotion on it.
oh, yeah. Just
Yeah, just
water
get it
wet
real
or
wet.
lotion wet.
Yep, get it real wet with water and then even more lotion. You know, even if it's more hair, because that's what we do in veterinary medicine.
Oh, that's a good, see, that was the pro tip I was looking for. Thank you. Yeah,
Cervical.
because again, if there's not, you get that little jolt. So that's kind of why I left that video in. He's subacute. He came in saying I was feeling pretty good. I overdid it, and now it was bothering him. So I wrote up the high tens to 25 because it was sore that day. But as you can see, his motion was pretty good. And there's the RET setting was deep because he's out of that acute stage. So I want to get some thermal effect on that. And then, the CET I had already done. The dispersive pads on the thoracic spine, because I know that's the next place I'm going. Because once he gets to be in that rehabilitative phase of care, now he's twitching is because I have the high tens on. I'm sorry, the high EMS on. I want to hit those motor points and I want to get the contraction of the muscles. And we want to go into the thoracic spine because, from a manipulative standpoint, we want to open up this. All right. Because when the thoracic spine is mobile, then you're going to get better engagement of your mid and lower traps. And when your mid and lower traps, now, if you can see upside down on the videos, you can see his setting there. Uh, but I pulled it over here for everybody, so you don't have to worry about it. He was at 25%. That was dynamic, by the way, for his high tens, because I want to make sure he's not getting soreness in there. All right. But again, the mobility stability continuum, Yanda's upper cross postural distortion. All right. Are we familiar with that? Where you get overactivity of the upper traps and levator scap are hypertonic, and your mid and lower traps are weak and dysfunctional. You're getting a forward head carriage. So you have to stabilize the cervical spine. We have to strengthen the mid and lower traps big time to shut down the upper traps. Because when the upper traps are tight, it just compresses the cervical spine. And we're trying to avoid that, treating cervical spine dysfunction. Does anybody use radial more or focal more? I mean, I'm more of a focal guy up in this area. Are people using radial for that upper thoracic and traps
I like
with
to
the
was
high
actually
EMS?
I like to start with radial, just to see, especially if it's the first time they've experienced win back. Um, and then if that goes okay, then I'll want to get that second layer.
You like to go a little, you like to go pretty, like how hard do you get those contractions going, Grant? I mean,
I
how
was,
much do you like to bring it up?
yeah, I start very low, like
Okay.
10%. Sometimes I will go down to 5%, and then especially around this area, I find that I can't go above 20, 25% the way that I do it.
Yeah, I
Now, are
agree.
you
I also like the Pain Free Plus. I don't know if you guys have used that. But what I've also found, and this is what I was going to ask you, Dr. Don, is there like a certain time when you're doing this EMS work that you like shoot for? Because I try, especially when I'm using like the Pain Free Plus EMS, I don't want to like overdo it. How do you feel about that?
Yeah, overdoing it's definitely an issue. In the subacute, the acute, time-wise, I'm in like that 10-minute range.
Mhm.
Okay. Rehabilitative, the corrective phase. I first time, I really try to hold the horses back and keep them under 15 minutes to see how they tolerate it. I've over treated people in that, in that range. So 10 I find is pretty safe. 15, you have to make sure they can tolerate it. I know the setting for Pain Free Plus is 20 minutes, but hitting them with that the first time out, even if you back off on the parameters, can definitely be too much.
Yeah, no, and I've definitely, especially when you're using the EMS, to try and kind of promote some soft tissue relaxation with the Pain Free Plus, I've definitely overdone it, and people can be like a little sore after.
Yeah. Yeah, but I also find that soreness is a different type of soreness. It's
Correct,
not like
absolutely.
that DOM soreness where it's like,
Yeah,
oh man, I can't move. You
yeah.
know, it's a little sore, but it doesn't quite linger the same way. So, I
No,
mean,
I absolutely, I agree.
now, but are you using it with the paddles, Dennis, for like 15 minutes? I mean, when I'm using on the paddles, they're probably 5 minutes of
Yeah,
the high EMS with the paddle, maybe eight tops. The
I'm three
rest would
to
either be
five.
CET or some or again the pads.
Yeah, when I'm administering the EMS through the handles, I'm 3 to 5 minutes.
Okay. All right. No, I think that's well, look, we had this guy at four. That's we had him here at 450, so it's not bad. Pretty
Mhm.
close. Pretty close. Um So anyway, in the rehabilitative phase of care, these are some ways to look at, but definitely using the high EMS is huge because it gets those motor points, it wakes up those muscles, and it gets them ready for life, for rehab, for strengthening. My perspective is slightly different when it comes to the active phase of care, in that I like to restore mechanics first. That's just kind of my headspace. So let's get back range of motion. Let's start thinking about, again, I'm a chiropractic doctor, the mechanics of the joints involved. Once I get those mechanics moving pretty good, but at least well enough where they can move pain free through 80% of range of motion, at least, then I talk about strengthening. Because to me, if I start to strengthen too early, I'm just reinforcing pathomechanics. So that's why I kind of stack things maybe slightly differently than Grant or Laura or Dennis do here. So comments, guys, what do you think?
I agree with you. I mean, typically when I'm working with someone, I'm trying to achieve a new range of motion. With a restriction, I'm trying to achieve a new range of motion, strengthen within it, and that's how we're going to maintain it.
Yeah, I would agree. I think that as we're gaining that range of motion, whether it be through the mobility or if it is a weakness, doing those end range isometrics and continue to push and make them chase that new range isometrically has been successful for me too. But again, you've got to you have to restore the motion, whether it be through mobility or through strength.
Well, that's a good point, Laura, about the lack of mobility could be a strength issue too. It's a
Hey
good
Don,
point.
we've got a question coming in from Scott who he asked a little bit and we've kind of hit some of it, but I want to make sure we get his question fully answered about the contractions. Um, he's asking expected outcomes, elimination of the contractions. How does he think about those with the high EMS contractions?
Uh, I, uh, I didn't get the question. Try it again. Is it
Yeah,
is it in the
no.
chat?
It is so this is about the high EMS contractions. Are those trigger points being eliminated? How do I think about these? And he's asking sort of what in the chat,
Okay.
what's the expected outcome?
Got it. Got it. Um, Generally, I mean, in my humble opinion, I don't think these are active or latent trigger points necessarily. They're motor points. If they're tender, there may be some latent trigger point components to it. So there's two ways to look at it. If they're in that subacute phase and I'm using the high EMS, I do want to kind of work out those sensitive areas, maybe throw some high tens on it. In the rehabilitative phase, I'm looking to start to wake up the muscles and get better motor recruitment and firing patterns. That's the way I look at it. Laura, Dennis, Grant, how do you guys look at it?
I agree with you 100% with the caveat that if I'm using the pain-free plus, that one is designed, that current is modulated in a way to better promote soft tissue relaxation. So that's where, that would be my only caveat is if I'm using that, the goal is, soft tissue relaxation.
So that's a true classic active trigger point or maybe a latent trigger point.
hmm That's how
Okay.
that's how I use it.
I think the approach of stabilizing the cervical spine and mobilizing the thoracic spine um, seems to be something that my patients understand that come in feeling like, oh, I want someone to just like stretch my head off. Like I really want to stretch more. And along the lines of stabilizing the cervical spine, which we're doing with some of these EMS features, and then we are, I think, kind of unlocking the thoracic spine with, among other things, the polyfrequency treatments. I find that it helps people attach to this idea that we don't want to keep stretching the neck because the muscles might be the way that I like to explain it is the body's doing a good job trying to protect itself. Let's find a new solution. And I find that the treatments that like when they feel, oh, there's my thoracic spine, we're going to engage those muscles when we want to look behind us in the car. That's something that is coming up for me in the way that I approach this phase.
No, that's huge. You got to get that mid, the scapular retractors, depressors, all those guys really engaged. That just offloads the neck and it's happy. And then we can rehab it. So that's great, Grant. Oh, I think that's great. So Scott, I think that got your question. If not, rephrase it and we'll go after it again. No, thanks for that's a great question. But if you do ultrasound trigger point, and if you're kind of trying to relate to what this is far superior. It penetrates deeper. It gives you better analgesic effect, and you get the TECAR, which is going to give you that circulatory effect that you just don't get from ultrasound. So it's same kind of concept, but far superior because the physiology and both the muscle stim being used as well as the TECAR are just better modalities, than interferential and ultrasound. All right, return to play. Return to play. Goes right back to what you were kind of saying, I think, Grant. I use the bracelets and lots of lotion. All right, that's the pro tip. Now, this is the patient that we've been following for this. And this guy did actually get banged up in an accident. And then I love YTAs, okay, because we're getting that engagement here, right? So this is all strengthening. This is staying relaxed. Now, is that helping his intrinsic cervicals? No. Is it helping those guys we were talking about the first two slides? No. But it's giving him some strength. And now I have him on the rehab plus because he's a relatively fit guy. And now we can really start working on getting it strengthened up. Okay. So we'll have him on bracelets and I'll put one pad in between his shoulder blades or in this case, I have two pads paraspinally on the cervical, on the thoracic spine for those mid and lower traps. So that's one of my favorites for that. The cervical spine, we have a picture of it under chronic pain. You can do supine and do chin tucks. But any insights from the academy on how we're going to get cervical spine engagement enhanced besides using the wands? Dennis, do you find with with the bracelets, if you get that on the cervical spine, that helps with the motor recruitment? Or what do you think?
Yeah, I like doing like some like muscle energy techniques here for
Hmm.
contractility. So like isometrics where I'm holding, I'm cradling the patient's head and having them like, move into rotational isometrics or even flexion, not so much extension, just out of what I'm thinking of. But certainly rotation. And I'm just, careful about obviously where I'm putting my hands and my fingers. But
Hmm.
yeah, no, I like it a lot for that kind of stuff.
So if you're using the bracelets, and you want to do some work on the posterior cervical spine or
Mhm.
your anchor hand, where you're going to get the authority, the overpressure hand, do you put
Mhm.
like a towel there, or do you just use a finger touch, or
You know,
how do
I,
you kind of offload that? How do you like to offload that? Prevent it
I'll
from, keeping the current focused on your contact hand versus your stabilization or overpressure hand.
So I do it with two bracelets on, and I kind of have, I am fortunate I have big hands, and a lot of the times I can, cradle like the occiput. I'm doing what Laura said though. I'm wetting the base of the skull so that I'm able to administer the current like a little more fluidly. And then with my other hands, almost on the patient's temples, I'm taking them into rotation, and then I'm having them
Hmm.
resist against me. I've also done it like you're saying, where like for like an upper trap, kind of like into like a lateral flexion. But then I'm still using two bracelets and I'm just, laterally flexing them with one hand away, having them push in against, shrugging into my hand with both bracelets on me.
Got it. Yeah, no, because I find I have to be careful with that non-contact hand. The one hand that you're over the
Absolutely.
lever scap, the other one you gotta say. Sometimes I'll just take a towel, put a
Yeah.
towel there, so I don't have to because I'm on their hair, and I haven't been using the wet it down technique.
Yeah.
But some of my female patients may not want to walk out of the house with a out of the office with a half wet head, though.
It's true, and it can get, a little messy, but yeah, it does work very well. It's just, depending on what your female patient's doing after, she may not want to have like a damp, lotiony head.
Yeah, Dennis, I think
Oh,
there's a fair number of us that would say if we've done our hair for the day that you're not messing up that hairdo.
100%. And I get that.
Uh,
I get it.
we've got Don, we've got Mauricio suggested. Have you guys tried cutting the stickies to target the cervical area more precisely, like right in the middle, separating the two silver sleeves?
no.
No,
No, I
no,
haven't done
Mauricio.
it. I won't do it. I won't recommend it.
Cannot do that. You cannot cut these pads.
Yeah, yeah,
There you
no.
go.
You
It is an
cannot.
issue but that's why you use the small little RET round bobble one, the round convex RET head is how you can get on the cervical spine. You can get high EMS through it, and even the high tens and get a good authority on it. That's how I get around it. But yeah, don't cut them.
On that note, do you, Dr. Don, or anybody else use the fractal head in this area?
Yeah, again, my only challenge with the fractal head is making sure there's enough lotion. Otherwise it gets real hot real fast, gets uncomfortable. But I have no problems with the fractal head up there. And anybody else? Any comments on that? So here's just bracelets, Dennis. I'm not like, I never use bracelets, but I use them more when I can do my pin and stretch. When I know I can get in there and I can really get authority. I can do mobilizations on the neck, okay? So these are, and you can do all your ischemic compression. So this is where bracelets for me is where I dive in when they're out of that acute phase and I can just go really after all those fascial densifications, all the myofibrosis that's in there, and I can even go in and do my CMT with the bracelets on. Now, for patients that come in and say, "Oh, you're not going to make it crack, are you?" Well, this is how we get all of our mechanics restored in the cervical spine without making a crack, too. But this also goes back to that first slide or second slide. See it, that's the subocciput we're working on there, ART. But this is, I can check all those mechanics. Are all those vertebrae doing what I want from the occiput all the way down to C5? And, whether you're doing a high velocity, an H-field grade 5 like that, or if you're going to do low velocity, doesn't make a difference. Bracelets work great at just getting all the mobilization there. So I do use the bracelets for full disclosure. Dennis Donovan.
I love it. I love seeing it.
There you go. So real quick, everybody's mentioned it. WinBack is a tool that works the best when you stack it with everything else in your toolkit. All right, 2 studies, one from 2021, one from 23, multimodal treatment approach, including exercise and manual therapy for neck pain. Overall clinical guidelines recommend CMT for the management of neck pain in combination with other approaches. And you've seen how the WinBack is integral with all those other approaches, and it just makes it better. TECAR with TENS, with EMS, money. A couple of slides on chronic neck pain, then we have time for a few more questions. We've talked about TECAR for pain control. We've talked about HVLA for the thoracic spine because we want to offload the cervical spine for creating more stability coming from the thoracic spine. Yes, we need to stabilize the cervicals and it's a progressive return to function. So that's a 2023 study. Landenberg starts with visual synkinesis. So everybody, put your fingers on your suboccipital muscles, right? Look straight ahead, your fingers on your suboccipital muscles, look left. Don't move your head, just your eyes. Look right, just your eyes. Look up, look down. You feel that oculomotor reflex? When your head doesn't move, but your eyes move, the suboccipital muscles are engaged. Put on the bracelets, get on the suboccipital muscles, and then you have people do visual synkinesis. Look left, diaphragmatic breathe. Look right, diaphragmatic breathe. And that's how you start your chronic neck pain people in their rehab. From there, you add isometrics. From there, you add resistive load. And you can even then go into the deep cervical flexor engagement using the test of Joule with the pressure device under the occiput, or you can do MDT, McKenzie for the extensors, all right? But that's your treatment for chronic neck pain. And this is a study from 2013 from Lanigan, wasn't with WinBack, but you take her approach and you just put bracelet on the suboccipitals. So the patient's in supine neutral, and then they have them just look down as an isometric, just looking down, nothing else. When they can do that, then you have them look down with overpressure with an isometric. But imagine doing that with your fingers on the suboccipital muscles with TECAR going through. It's going to really be fantastic. Now here, she's doing an isometric, looking down, chin tuck, but the head's just slightly above the pith, just a little bit, all right? And then lastly, a reactive isometric, look down, chin tuck, and lean away. It's not cervical flexion, it's a reactive isometric. So those are the 4 stages that Landon Lovinson did back in 2013. I stacked these with Winback for those suboccipital muscles. And for your chronic neck pain, it's money. It's just money. But Dennis, here's another, sorry, one more slide, then I have a shout out for you. Muscle back, right? Why do I put it here for my cervical spine syndrome people? Well, with motor vehicle accident, 50% end up with low back pain. So we want the return plate on the low back, and then we're activating the upper back, for strengthening. But, Dennis, everybody wants a technique named after themselves, right? So I was going to name DeFabio glides, but you stole my thunder, where I put isolated dysfunctional facet. I do overpressure on it as the windback's going through, kind of like a snag. Okay. But the DeFabio glides because, I do a contract, relax, muscle energy technique at the same time. But just like you said, works really great. I recommend it all the time. So that's pretty much it for me. But were there any other questions, Ramona, or from the Academy? Comments from the Academy? What do you guys think we should do?
Don, I'm just going to say, I'm going to let them have a moment to say any comments from the Academy. But as someone who has chronic neck pain from old whiplash injury, this was fascinating and gave me so many ideas.
Yeah, good. I'm glad you got some good info. And, we're going to get you set up on some cervical isometrics with visual synkinesis, and you're going to get rid of that chronic neck pain.
Even just done that exercise of feeling the suboccipitals is wild. That's so cool.
Yeah, it's huge. You don't always have to be, big, heavy, sexy, exciting exercises like isometrics and visual and respiratory, movement patterns sometimes are the home run.
Hey, Don, I'm going to throw one in there for us. For those people who are instrument-assisted soft tissue users in the cervical, specifically that HG7 tool for that OA and that OA upper release instead of your fingertips if they're wearing out. Same thing with the bracelets on and then holding that HG7 tool, whether it's a Hawk Grips or whether it's a Graston tool, while you're doing that release. Again, that TECAR energy is going to go through that stainless steel tool, that HG7, at the same time. So I combine it with the tool work too.
Oh,
Whoa,
I
cool,
love
Laura.
that. I love that. Now, Laura, let me ask you a question. Where would you introduce ISTM with TECAR in the treatment continuum? Where do you jump in with that with these? Let's just keep the cervical spine today. Let's not talk about ankles.
Yeah, no. As soon as you, like in this case, as soon as you have OA dysfunction, and it's amazing to me sometimes when you utilize, if you're just doing a release, just your fingertip release into that OA, how many people, if you put your fingertips in there versus the tool, you don't think they're going to pick a stainless steel tool over your fingertips, but often they do because of the consistency of pressure across that tool. So I'll start it as soon as they're comfortable and if they need that OA piece of the puzzle.
Yeah, cool. No, but thank you. That's one thing I didn't include the ISTM with the TECAR. Again, it's layering all these different modalities together, and you just get better outcomes.
Right. And it's whatever you do as a clinician. Like it's like you guys, you're a masters with your hands and I need some tools to be better with my hands. So it's whatever's in your toolbox that you're utilizing. That's the beauty of TECAR is it just makes your toolbox even better.
Mm-hmm. No, agreed.
Well said, Laura. That's it's like you do this for a living.
I was Mauricio had asked a little bit more about visual synkinesis. It's using your eyes with movement to facilitate motor engagement. So in other words, if you're working in a flexion movement pattern, you're generally looking down. So, if you're looking in an extension movement pattern, you're generally looking up. So let's say you want to do a post-isometric relaxation of the hamstrings, and you bring them up to the point of tissue tension, and then you have them contract. As they're contracting, going, away, going into extension, they'll look down. And then as you stretch them and you're bringing them up into lengthening, they look up. And you can do left to right movements as well with that plane of movement. It's just another way to facilitate motor programming and get the brain more engaged. That's how I explain it. I don't know. Dennis, how would you explain it?
Don,
I
I
guess you're
would
muted still.
sorry about that. I wouldn't explain it any differently than you did. And I appreciate the shout out. It's nice for me to see that some of my techniques overlap with a legend like yourself. So
You
really
guys are way too nice.
really awesome stuff, my man. I love listening to you because I always learn something every time I get the opportunity.
Well, look, right back at you. It's been a wonderful evening. Everybody knows where to get me. Laura, Ramona, I think I'm throwing it back to you. Let's start and
Okay. Yeah.
get ready for you.
Yeah, no worries. Dawn, as always, a phenomenal presentation. It's always fun to hear your unique approaches to how we work with our patients. Thank you everyone for joining us for this month's Win Back Academy Ask Me Anything. It's always a huge shout out to you, Dawn, but also to our other panelists. I think of our new format podcast, this was probably the most interactive we've had, and I really enjoyed it. It was great to hear from everybody on the panel. I think that's what makes these conversations so valuable, is hearing all these different approaches that clinicians take for these complex cases, while still keeping that patient care at the center of the discussion. Quickly, a quick announcement for our friends who are tuning in. We do have next week Laura leading a CE webinar on, no, not next week, I'm sorry, 2 weeks, the first Tuesday of the month, which is in 2 weeks. I keep thinking this is the last week of May. Which will be on the knee. So if you were interested, earlier, Laura made some mention of that. We'll have our registration on our website. That one will be eligible for a CEU. And as always, we hope to keep these conversations going to give you practical ideas, deeper clinical reasoning, and new ways to think about how you integrate TECAR into your own practice. If you joined us live, thank you for being here, for the good questions, the discussion. If you're listening back on the podcast replay, we appreciate you being part of the Win Back Academy community. And finally, be sure to join us next month for our AMA, where we'll be discussing facial recovery, including TMD, TMJ, peripheral facial conditions, neural palsy. And Don will also be leading that with a special guest, Jesse Chalnick, who was with us in March. Thank you to everybody, and we'll see you next time.
Thank you. Appreciate everybody tuning in. Have a good night.
Love me.